Hello, my name is Virginie Lafage. I'm the Senior Director of Spine Research at HSS in New York. So I'm going to talk about the chapter about the evaluation of spinal alignment. And the chapter and this presentation, really like the objective is to provide a step-by-step approach to spinopelvic analysis. So basically we're going to describe the most common parameter, talk about compensatory mechanism, the clinical relevance of those parameters, and illustrate this with some case presentation. It's very important to keep in mind that sagittal alignment is just a tool to evaluate your patient. By no means this is a new indication for surgical treatment. So let's talk about the most common parameter, and basically we're going to cover like everything from the pelvis up to the cervical spine. So what is sagittal alignment and why does it matter? Basically, sagittal alignment aims to answer like two different questions. The first one is like, what type of shape, spinal shape do we need, or curvature, in order to adopt standing posture without using a lot of energy while maintaining a horizontal gaze? The second question that we're trying to assess is like, what is happening when this shape is compromised? That means that, for example, when a patient loses some lumbar lordosis due to age, degenerative process, deformity, trauma, or even suboptimal surgery, how does the patient compensate to maintain a standing posture? It's important also to keep in mind that alignment is more than the spine. And the reason is that the spine sits on the pelvis. So really the pelvis can be seen as the regulator of the alignment between the spine above and the lower limb below. The pelvic parameters were first introduced by Madame Duval-Beaupre in 1992. She talked about pelvic incidence, pelvic tilt, and sacral slope. So let's describe a little bit more in detail those three parameters, starting with the pelvic incidence. So basically the pelvic incidence is the angle between a line from the femoral head to the center of the sacrum and the perpendicular to the sacrum. What is more important than knowing how to measure this parameter is really to understand the meaning. So let me show you an example. This is a pelvis with a small pelvic incidence, and this is one with a large pelvic incidence. So one way to think about the PI is that it's measuring the orientation of the sacrum within the pelvis. So pelvic incidence is a morphological parameter in the sense that it is not affected by the patient position. The average pelvic incidence in a Caucasian population is about like 52 degrees, but there is a very large variability in the general population, anywhere from 35 to 85 degrees. Pelvic incidence increases during childhood and then stabilize and doesn't really change with age, except maybe when you reach like 65 or 70 years old. The second parameter that I want to talk about is the sacral slope. So sacral slope is quite easy. That's the angle between the horizontal line and the sacral plate. And the reason why this parameter is important is because in asymptomatic population, it's going to dictate the amount of lumbar lordosis. Because think about it, the lumbar lordosis starts at the level of the sacrum. So if you have a very tilt sacrum, you're going to have a large lumbar lordosis. It is a compensatory mechanism in the sense that this parameter is going to be affected by the patient population. In young adult, the average pelvic sacral slope, is about like 40 degrees. It tends like to remain stable during childhood and then to decrease with age. Finally, the last pelvic parameter is the pelvic tilt. So that's the angle between a line from the center of the femoral head to the center of the sacrum and the vertical. So because our reference is a vertical, that means this parameter is going to change based on the patient position. So here again, we're talking about a compensatory mechanism. So one way to think about the pelvic tilt is that it's just a measurement of the pelvic rotation. So let's look at like this schematic representation of a flat back. So you can see like the trunk tilt forward, very large SVA, and not just by turning the pelvis backward, so pelvic retroversion. The patient is able to bring back the spine in a vertical position. And that's really one of the very strong way that the patient can use to compensate. So now that we know about all those pelvic parameters, the question is like, well, how do you use them? Are they actually useful to identify like the ideal amount of lumbar lordosis? So for this, I want to introduce you to the slope-to-slope concept. So what does it mean? On the left, you have a subject with a large pelvic incidence and therefore a large sacral slope. In order to maintain the spine in a vertical orientation, because there is a large sacral slope, you're going to need a large lumbar lordosis and therefore a large thoracic kyphosis. On the other hand, with a small pelvic incidence, you're going to have a small sacral slope, and therefore you don't really need any big curvature in order to have the spine in a vertical position. So let me give you an example. Two patients, same lumbar lordosis, like about 40 degrees, but you can see like the alignment is quite different from the patient on the left to the one on the right. The reason is that they have very different pelvic incidence, 35 degrees on the left, 76 on the right. So the same 40 degrees of lumbar lordosis for the patient on the left is actually appropriate. For the patient on the right is actually a flat back. So this brings the question, like, how much lumbar lordosis do we need based on the PI? So the very rough estimate is that you want to match the lumbar lordosis to the pelvic incidence. This is a very like a general rule that will at least get you started. Now, if you're very familiar with the PI and LL matching, you can go a little bit further and start to stratify the amount of lumbar lordosis based on the pelvic incidence. So here is how it works. Basically, if you have an average PI, you want to match the lumbar lordosis to the PI. If you have a small PI, you want the lumbar lordosis to be equal to PI plus 10. If you have a large PI, you want the lumbar lordosis to be equal to PI minus 10. So you can see like we are within like the 10-degree rule, but now we can customize the amount of lumbar lordosis a patient needs just based on one single parameter, the pelvic incidence. So in addition to the amount of lumbar lordosis, it's also quite important to think about the distribution of the lumbar lordosis. So overall in the general population, we know that L4-S1 represents 2/3 of the total lumbar lordosis. We recently published a study to investigate if the amount of proximal lordosis and distal lordosis were affected by the pelvic incidence. And what we found was quite interesting. Basically, we found that the L4-S1 segment seems to always be equal to 35 degrees, independently of the pelvic incidence. What changed when you go from a low PI to a high PI is that the proximal lumbar lordosis increased in terms of degree, so from 16 degrees to 30 degrees. So what does it mean? It means that subjects with high PI need to recruit more level in their lordosis than subjects with low PI. So how do you integrate all those concepts in your clinical practice? Basically, measure the pelvic incidence, categorize that as small, medium, or large, then calculate the need in lumbar lordosis, so PI plus 10, PI minus 10, and then think about the distribution of this lumbar lordosis. And again, like, we are able to identify like the curvature of the lumbar spine and the distribution of the lordosis just based on one parameter, the pelvic incidence. So let's go back to our concept, or slope-to-slope concept. We talk about the association between pelvic parameter and lumbar spine. Now let's talk a little bit about thoracic kyphosis. Using the same database of asymptomatic normative subjects, we realized that the mean T1, T12 thoracic kyphosis was actually equal to 50 degrees, so much higher than whatever we usually have in mind. and thoracic kyphosis represents about 40% of the lumbar lordosis. If you want to go a little bit more into detail, we realize that independently of the age and the curvature of the thoracic spine, T7 was always the most horizontal vertebra, and the maximum kyphosis ranged from T1 to almost L1. Now let's talk about the cervical spine. So whatever we describe in terms of relationship between lumbar lordosis and sacral slope is actually applicable to the relationship between the cervical lordosis and the T1 slope. And this concept was actually described in 1988 by Thierry Marnet. What do we know? We actually know that in 1/3 of the asymptomatic population, the C2 to C7 cervical alignment is actually a kyphosis. So 1/3 is quite a lot. So what does it mean? Let me show you like 4 examples. From left to right, you have a flat T1 slope, and then like on the right, a very steep one. And as you can see, like the patient adjusts to the T1 slope by either having like a kyphotic alignment, a straight cervical spine, or a very pronounced cervical spine. So think about the cervical spine as being held between, on one end, the cranial vertebra, so the need to have an horizontal gaze, and on the other extreme, the T1 slope. So again, this concept of slope to slope is actually applicable from pelvis to lumbar spine to thoracic kyphosis, thoracic spine to cervical alignment. Now that we know everything about the curvature of the spine and the pelvic parameter, let's talk about global alignment. So there is numerous parameters in the literature. My advice is like to pick one single parameter, know the advantage, know the limitation of this parameter, and stick with it. So the most common parameter is the SVA, sagittal vertical axis, was described by Jackson in 1994. And basically, it's the offset between a plumb line from C7 and the posterior superior corner of the sacrum. You want the SVA to either fall over the sacrum for a young adult, a little bit in front of the sacrum for an older subject, but rarely in front of the femoral head. What do we know about the SVA is that, well, it tends to increase with age. Another parameter that you can use in complement or instead of the SVA is what we call the TPA, T1 pelvic angle. So this is an angular parameter between T1, the femoral head, and the sacrum. Because it's an angle, it doesn't require you to calibrate the X-ray, and it's really a measurement of the deformity. So let me show you a case example that illustrates a rotation of the pelvis. So you can see like from left to right, when you have a pelvic retroversion, the SVA decrease. And that's to be expected. On the other hand, if we were to use the TPA, you will have a constant measurement in the setting of a fixed deformity. So now let's talk a little bit about compensation. And really like the question that we're trying to address is, how does your patient react to a loss of lumbar lordosis? If you want to know more about compensatory mechanism, this is a very interesting paper from Cedric Barré that describes like the different compensatory mechanisms and also talk about like this concept of driver of alignment versus compensation. So one very common way to compensate will be like a flattening of the thoracic spine. So look at this illustrative case. You have a loss of lumbar lordosis associated to a thoracolumbar kyphosis and a very flat upper thoracic kyphosis. So basically the patient is trying to hyperextend the back to bring back the spine in a vertical position. Another illustration of this concept of using the spine to compensate for deformity or malalignment is this case example. of a 58-year-old male with a history of chronic back pain, leg pain. And basically, when you look at the images, you realize that L4S1 is almost flat, and you have an hyperextension of L3, L4. So this patient is extending the segment adjacent to the disease to bring back the spine in a vertical position. Another way to compensate that we already mentioned like earlier in this talk is a pelvic retroversion. So by turning the pelvis backward, you will bring back the spine in a vertical position. So again, like a schematic illustration. When the patient retroverts the pelvis, the hip ends up to be in hyperextension, and this will affect the ability of the patient to walk normally. You also have to be very careful to patients that do not compensate using those pelvis. The reason is that those patients usually they have additional conditions such as stenosis, neurodegenerative problem, or hip problem. So here you have a case example of the 72-year-old with leg pain, 90%, and back pain. This patient is what we call like a positional malalignment. So basically the patient actively decreases the lumbar orthosis to open the posterior neural arc and decrease like the radicular pain. You can see here, if I just put the measurement, we have a SVA of 25 centimeter, a PILL of 40 degrees, so a huge loss of lumbar orthosis, but the pelvic tilt here in green is totally normal. This patient sustained a multi-level decompression, and you can see just with the decompression alone, by removing the painful element, you restore some form of sagittal alignment. So, in conclusion, what did we learn today? We learned that this concept of harmony, so harmony between the shape of the pelvis and the curvature of the spine. We also learned about a reproducible process to do a sagittal plane evaluation, one parameter after the other. We learned also that we don't need that many parameters. Pelvis is the foundation, so you want to measure the PI and the pelvic tilt. And from that, you want to estimate the lumbar orthosis, so the overall L1S1 lumbar orthosis and the distribution. And most of the time, this will be sufficient. If you have a more complex case, then maybe you want to add the thoracic kyphosis and the SVA. Thank you.